Uh, Good afternoon, everyone. First of all, I thank the organizers and Dr. Ashish Singh for inviting me to this wonderful meeting. A lot of learning for me also because I am also just learning this system, and the principles are almost the same for all the system. It is just the tool, and you should know how to use it. Now, we all have seen how technology has changed our lives. That was in 70s and that is in 2022. And in the medical field also, we have seen that the technological advancement have really changed the way we do surgeries. That was how arthroscopic surgery was done earlier, and now we have the latest image management systems and everything. We just discussed about augmented reality, which is coming into the orthopedic surgical practice. Now, the robots are basically computer programmed machines which can perform a repetitive task with much greater efficiency, accuracy, and consistently without getting fatigue or getting bored. Okay? We all know the application of robots in manufacturing, in software, mobile technology, and laptops, and in the healthcare. It's being used for many things. For the patient care, in oncology and neurosurgery, it has been used for quite some long time. In hair transplant, where it has to just do that repetitive task, it's a very important tool. In physiotherapy, it's being used. Now, if we talk of orthopedics, one of the commonest surgery being performed is knee replacement, and with very consistent good results. All of us have these kind of results even with conventional surgeries, okay? Where if you do proper balancing, if you do the alignment properly, you can get a very good results. So the patient can do their activity of daily living quite easily, and they can even do recreational activity, like this person who is around 80 years of age is participating in this traditional martial art. But still there is a dissatisfaction rate in literature, say around 10 to 15%. Now, in order to get a good result, there are two basic goals. You need to align the limb properly, the component position should be accurate, and the balancing should be good. So, orthopedic surgery, as I feel now, is more and more about soft tissue. Even though you are doing a knee replacement, you are putting an implant in the bone, but it is the balance of the soft tissue which really determines the function of the knee joint. So, this balancing is very important. So, in conventional surgeries, the literature have shown that the degree of malalignment is slightly more, and this happens because of inappropriate positioning of the jig or movement of the jig while doing surgery. That is supposed to cause malalignment in almost 20 to 40% of cases. Now, if we talk about problems or which we face in conventional TKR, is that we use intramedullary jigs and extramedullary jigs for taking the resection. Now, there can be a lot of individual variation, and then again, the jigs and guides have limited options. Like today we saw that Dr. Santosh had this capacity to move the femoral implant proximally. Now, this sort of thing is not possible with conventional jig. You either can take either 9 millimeter cut or 11 millimeter cut. So, you can't take cuts according to the way you want. Similarly, there is also component play while taking the cuts. So, that sort of things lead to sometimes malalignment. And then there is no provision to assess the soft tissue balancing, which is possible nowadays. So, that's why TKR in present times is considered an art. So, experienced surgeon with their experience and expertise, they know how much to resect and how to balance. Okay? But with robotics, we bring an objectivity to that art. So, it's a tool which helps the surgeon to more precisely align and balance the implants with computer monitoring, which helps to improve the overall function of the joint. So, this is the usual workflow for any robotic surgery. First is, there is a software which converts the images to a patient's personalized 3D knee joint. Second part is it allows you to do planning on that 3D model. So you can find out, or you can find out the accurate component size, the positioning, how much bone dissection is needed. So that's the second part of the workflow. And third is execution of the plan with high level of accuracy and precision. Okay, and also it allows intraoperative tweaking of the plan if required. So that's the usual workflow of any robotic system. We discussed about the types of robo available. These are the different types which are available in our country now. Now, if we talk of this QVIS, it is an autonomous robotic system. As we saw that it can work independently after you have done the planning. It is CT scan based. So CT scan images are used to create the 3D model of the knee joint. And it has got a milling tool instead of saw. So the planning is AI based, artificial intelligence based, and the execution of the plan is by robotic arm with sub-millimeter accuracy. That's how the planning is done. The software gives you these kind of images. So that is, you have to just pick up the center of the hip joint. You pick up the center of the knee joint and the ankle joint, and then it will give you an image like this. It will automatically determine the size of the implant and position of the implant. But then you can change it according to your judgment. You can downsize the implant, you can upsize it, you can make the distal cut more proximal or distal. So at the end of your planning, you can get an image like this, where you will get the size of the implant, the amount of resection which will be in the distal femur or posterior femur, the amount of resection which will be in the tibia, whether you are able to get the alignment which you want, either mechanical or kinematic alignment, functional alignment. So all this plan will come a day before the surgery when you have done the planning. So basically you are doing a virtual surgery before the real surgery. Then the next step is execution. So we just saw that how it works. It works autonomously, and it bursts, it tunnels through the bone and takes the cut. Okay, and while it is working, you can have a real-time picture of the portion it is cutting. So it is always coming from the medial aspect, from the anteromedial part of the arthrotomy. So you don't have to evert the patella. Okay, and it always leave a ledge of bone on the posterolateral aspect, both on the femur as well as on the tibia. So the soft tissue, chances of soft tissue damage is almost nil. So that's how we do it. After the planning, you register few points on the both femur and the tibia, so that the robo, it correlates the plan with the actual knee. You do the gap balancing. So you can do the gap balancing by making changes in the cut. Once you are okay with the balancing, both in extension and flexion mediolaterally, then the robo takes over. So we just saw how it does. It automatically takes all the cut. On the femoral side, it has to take 5 cuts, the distal cut, and both the chamfers, anterior and the posterior cut. Someone was asking about the synovitis part, because it is constantly being bathed with the saline, so the chances of synovitis is quite less. And in fact, it also prevents the damage due to heat generated. So it constantly shows you the real-time image of how the burr is moving. So this boundary is set by the software itself, which understands the bony boundary according to the CT scan, and the surgeon can also move this boundary. This arm can move in 6 axes. So it can go, it can also take the cut posteriorly without causing any damage to the soft tissue. You just have to make sure that these arrays are not coming in the way of this milling tool. So at the end of the cut, you will get a picture like this. Now you have to remove some lateral bone and the posterior osteophytes, and over that you can put your implant. Now, because the soft tissue damage is very less, you haven't really, like today morning also we saw that the soft tissue sleeve was totally maintained. So the pain is very less, and sometimes you can be surprised with the kind of recovery the patient gets. Even with bilateral knees, the patient is using this walker just as a prop. Now, there are a few safety features. Now, if you see the studies, the active robots have been found to cause some damage to the soft tissues, but that was with the first generation RoboDoc. With the newer generation active robot, there have been few safety features which prevents these kind of injuries. So first is that if there is any bony movement more than 2 millimeter, it will stop automatically. And secondly, there are these haptic boundaries which prevents the milling tool to go out of it and cause damage to the soft tissues. And even within these boundaries, it cuts less than what it actually shows. Now, we have seen that with this robotic thing, the requirement of opioid analgesia has reduced. The time to SLR and maximum knee flexion has also increased, and there is smaller drop in hemoglobin because you are not opening the medullary canal. So the blood loss is also quite less. The other potential benefits includes that it requires less physical work and less retraction. You require less instrumentation and fewer surgical trays. So, in conclusion, if we see that the robotic assisted TKR has got a shorter learning curve, as we discussed, it requires almost 15 to 20 cases to get the timing equal to that of conventional, but the accuracy you can get from even first case. You can get a perfect pre-op planning. There is greater component accuracy and precision. You get soft tissue protection, less surgeon and surgical team fatigue, and there is increased patient satisfaction. So robotics is only a tool in surgeon's hand to perform knee replacement more accurately, and it helps the surgeon to execute their plan more precisely. Either you want to do mechanical alignment or kinematic alignment, it's your choice. Everything works. It's either your way or my way. There is no right or wrong way. But the robotics help you to do that planning, to execute that plan in a much better way. So again, things go back to the same thing, that you have to learn the principles. Okay, robotic helps you in doing those, follow those principles more rigidly. So if you know the principles, you can devise your own technique. But if you just know the technique, then you will be stuck with only one technique. Thank you.
Our next speaker is Dr. Ramakant sir, and I would like to call